Myxedema as a rare cause of cardiac tamponade. The authors report that they do not have any relevant financial relationships. Objective: Myxedema coma is a very rare manifestation of severe hyperthyroidism which occasionally presents with cardiac tamponade. We present a case of myxedema coma secondary to Hashimoto's thyroiditis complicated by adrenal insufficiency due to Addison's disease, resulting in cardiac tamponade and cardiogenic shock. Case description: This is a case of a patient with a past medical history of hypothyroidism diagnosed 2 weeks before the admission, who presented to the hospital with chief complaints of fatigue and shortness of breath. The patient reported that he was prescribed levothyroxine 100 micrograms daily, and he initially was taking the medication but eventually changed his mind and discontinued it due to worsening shortness of breath. On a physical exam, the patient was found to be hypotensive and tachycardic. POCOS was performed at bedside and revealed pericardial effusion. Due to suspected cardiogenic shock, the patient was started on norepinephrine and phenylephrine. The patient had urgent pericardiocentesis. Repeat echocardiogram after the procedure revealed minimal pericardial effusion. Laboratory test results revealed TSH of 148 microinternational units per milliliter, positive thyroid peroxidase antibodies, and thyroglobulin antibodies, negative ANA. Cytology from the fluid revealed multiple neutrophils, but fluid culture was negative for bacteria or fungi. Adrenocorticotropin hormone stimulation testing was consistent with adrenal insufficiency, and adrenal antibodies testing came back positive with a titer of 1 to 20. The patient was treated with levothyroxine and stress doses of steroids. His TSH subsequently decreased down to 20 microinternational units per milliliter at the hospital. The patient was following up with endocrinologist outpatient, and on recent routine testing of his TSH, it was 2.85 microinternational units per milliliter, and T4 was 1.3 nanogram per deciliter. His dose of levothyroxine was consistently 100 micrograms daily, and his steroids were tapered. The patient was doing well and was compliant with his treatment regimen. Discussion: Pericardial effusion was presumed to be due to severe hypothyroidism. However, there was also a concern for the underlying adrenal disorder, as the patient had worsening of his symptoms after he was started on thyroid medication. Conclusion: Prompt recognition and treatment of cardiac tamponade should always be followed by investigations of possible causes of this medical emergency. Physicians should stay open-minded and always think about rare pathologies such as myxedema, which may also result in cardiac tamponade. Thank you.